So hello, I'm Daniel Higby. I'm a clinical research fellow here at Southmead Hospital, and today I'm going to be speaking about asthma with persistent airflow obstruction, which can also be called asthma with fixed airflow obstruction. So to start off with, we'll talk about what asthma is more generally, and then we'll focus more specifically on what asthma with persistent airflow obstruction is. And we'll talk about how this is different to a similar condition called chronic obstructive pulmonary disease, or COPD. We'll talk about how we make a diagnosis of asthma, how we treat it, and if there's anything that you can do to help yourself. So to begin with, what is asthma? Well, it's been around a long time. It was first described by the ancient Greeks 3,000 years ago, and if you translate it, it means to pant. And really, asthma is actually a collection of symptoms. It's more of a syndrome. And those symptoms are shortness of breath, cough, wheeze, and chest tightness. And these symptoms are all caused by variable airflow obstruction. And by variable, I mean the airflow is obstructed to different degrees at different times, and that's why sometimes you can get asthma attacks, and why sometimes people find they have worse symptoms at night. So what causes asthma? Well, most asthma is allergy driven, not all, but most of it. And that means people that have asthma often also have other allergic conditions such as eczema or hay fever. And if on the left of the slide here, you can see a picture of a normal airway. So if you imagine when you breathe in, air will go through your nose or your mouth, down the throat, divide into the right and left lung, and divide and divide and divide again. And it's these small airways that we're looking at. So in a normal airway, there's a nice big hole which all of the air can move in and out from easily, allowing you to breathe normally. But if you look at the picture in the middle, in people with asthma, the wall of these airways becomes thickened, and that reduces the flow of air, causing obstruction. And it's very similar to if you were to try and whistle just by pursing your lips. You cause an obstruction and a whistling sound. And this is exactly the same phenomena that happens when people with asthma wheeze. The airways become thick, and it's difficult for air to get through. The airflow is obstructed, and that also is what causes the shortness of breath. The airways also become very hyper-responsive and reactive, which is what causes the cough. And then sometimes, as you can see on the right, the muscle around these airways constricts down, and that's what happens in an asthma attack. And also there's a lot more mucus production, which means you cough more, you cough things up, which also adds to the obstruction of the flow of air through your lungs. So how do we measure this obstruction? Well, as you can see on the picture, this person's having their breathing test done. And I'd hope that everyone watching will have had this done at least once and probably multiple times. So you breathe as hard and as fast as you can through the tube. And normally we would expect someone to be able to exhale all of the air that they can exhale in their lungs. About 70% of that should all come out in the first second. If it takes longer than 1 second to exhale 70% of the air, we would say that's an obstruction because you're not able to get that air out. So some important points. Unfortunately, there is no one specific test for asthma. If there was, my job would be a lot easier, but there isn't at the moment. And lots of diseases are similar to asthma. So asthma is not the only disease that causes cough and shortness of breath and wheeze, or the only disease that has airflow obstruction. And so it can take time with specialist input and in-depth testing to specifically say if someone probably does or does not have asthma. So now we've talked about asthma more generally, I'll talk about asthma with persistent airflow obstruction. So I've got the same diagram at the bottom of the slide that you'll remember from before. But people with asthma with persistent airflow obstruction never have a normal airway. The airway is always thickened and inflamed, and so it's always harder for air to get in and out. And very specifically, even if we give medications to open up the airways, such as a nebulizer or an inhaler there that many of you may recognize as salbutamol or Ventolin, even if we give those medications, although the airflow might be slightly improved, even after giving the medications there still will be a degree of obstruction. And so that is asthma with persistent airflow obstruction. So what does this mean for you? Well, it means that the symptoms may be more persistent because you have that persistent obstruction in the airflow. So rather than feeling completely normal and just every now and then having an asthma attack, instead you may find that you have symptoms of shortness of breath, cough and wheeze most of the time. From a medical point of view, it means the diagnosis can be more challenging because most people with asthma don't have this. Most people with asthma will have variable symptoms and variable airflow obstruction. It may mean that we'll need to give you different treatments as well. So I'll just touch a little bit on chronic obstructive pulmonary disease, COPD, because it's a disease that's very easy to get mixed up with asthma with persistent airflow obstruction. The central difference with COPD is that COPD is always a persistent airflow obstruction with persistent symptoms, and generally it is caused by inhalation of noxious particles or gases, particularly cigarette smoke, so it doesn't tend to be allergy driven. But it's tricky because not everyone that smokes will get COPD. Only about 20% of smokers will get COPD. Equally, not everyone that has COPD has smoked. And of course, people with asthma can smoke as well as have allergies, which complicates things. And also, asthma is actually a risk factor for the development of COPD. So how do we tell the difference between asthma and COPD? Well, it isn't easy, and it's what I spend a lot of my time doing as a specialist. There are some clues and pointers though. So if someone developed asthma age 14 and has had respiratory and breathing symptoms all of their life, and they've developed a persistent airflow obstruction, then asthma with persistent airflow obstruction would seem to be the most likely diagnosis. Whereas if someone never had asthma when they were young and only developed breathing symptoms in their 60s or 70s having smoked, that would seem much more likely to be COPD. Also, we can do specific tests looking for the degree of allergy. So if some people on their blood tests or breathing tests have a lot of allergy and inflammation, again that would point more towards asthma. How do we treat asthma? Well, as you'll all know, we often divide treatments into preventer and reliever inhalers and treatments. So the idea is we want to prevent an asthma attack or even just a worsening of your asthma symptoms. And the way we predominantly do this is through inhaled steroids. And they're the real main treatment option because they're actually treating the underlying disease. They're treating that inflammation and they're causing it to reduce. So it's very important that everyone takes their inhaled steroids regularly. We also give airway relaxing drugs, which are technically called bronchodilators, and they will relax the airways down, allowing air to flow more easily. But they don't treat the underlying disease, so it's important that people take their inhaled steroids along with their salbutamol or their Ventolin. Also, if people do have an allergy component, then we can give some specific anti-allergy treatments. That's the preventer side of things, but it's worth remembering that even people with asthma with persistent airflow obstruction can still get asthma attacks. And so it's important that people monitor their own disease. I hope you all recognize what's on the left there. That's a peak flow monitor, and it's a very good way of getting a quick assessment of airflow obstruction. And if necessary, of course, hospitals and ambulances may still be needed, so we can give additional treatments on top of the preventer treatment. Is the treatment for asthma with persistent airflow obstruction any different to asthma more generally? Well, no, not really. The treatments are mostly the same. What I would say though is because there's always a degree of obstruction, we might give more medications to try and open up the airways and alleviate some of those symptoms. And so on the right there, you can see some medications that we'd be more likely to give to someone that has asthma with persistent airflow obstruction than someone that does not have that. What's also very important is the course you're doing now, LEEP, or Pulmonary Rehabilitation. It's a really excellent course that really alleviates symptoms and makes people feel much better on day-to-day life. It's also important to think about general health. It's not just about the lungs. Self-management is important because this is a long-term condition. There is no cure, although there's lots of things that can be done to make you feel better and safer. One thing is written asthma action plans. If you don't already have one of these, the next time you have an appointment with your nurses, I'd really encourage you to discuss it. And that's a written guide that tells you what to do should your asthma symptoms worsen. Another treatment that's sometimes used is rescue packs. A rescue pack is when people have a pack of antibiotics or steroids at home and they might take them before they've even accessed help from the GP, and it increases time, the speed with which they get treatment. I would say though that we don't always use them, and it's not always the best treatment for everyone. For some people, if they're bad enough to need tablet steroids or antibiotics, we'd prefer if they just went to see their GP or came to hospital instead. Physical activity is very important. Keeping as fit and as healthy as possible and maintaining any lung capabilities you have is really key. Are there any other treatments? Yes, there are many other things to think about. This is a long-term condition and it may impact things such as mental health. It may be that people are so breathless they'd require social support to help them cope with day-to-day living. People may have other diseases that also affect breathlessness, such as heart disease, so it's important that those are optimized and people are as well as they can be. Also, people sometimes get side effects or work better with some medications than others, so it's important that we always review people's medications and check that they're taking them regularly. If people's asthma is driven by an allergy and that allergen can be avoided, then it's important to do that where possible. So in summary, most people with asthma have variable symptoms due to variable airflow obstruction, but some people have persistent airflow obstruction, which means they can have more persistent symptoms. Really important things to do are to not smoke, which will worsen it, and also remember to take the medication, which will help. But it's also important more generally to stay healthy and active. Well, I hope that's answered all of your questions. Thank you for tuning in, and I hope the rest of the course goes well.